Hello, good evening everyone. So, Dr. Shubham, Dr. Akshay and Dr. Krishna. Yes. So, welcome everyone. I know we are getting a medicine recall has been quite tough this year because there have been a lot of varying conflicting things, but let us try to make the best of what we have. And even today you can help me with the chat box if how we can refine the question. So starting with the first one, so when we have the patient with features of right heart failure, so patient has got right heart failure, patient has got irregular pulse. So patient is having irregular pulse, we can say there is a patient having arrhythmia is present and there is a loud diastolic sound and JVP shows rapid Y descent on the cardiac examination. I have repeatedly told you in the class that when you get rapid or exaggerated Y descent, don't even think. Think of only one answer. Constrictive pericarditis is present. In the constrictive pericarditis, because of the elevated sympathetic tone, there is a risk of developing tachyarrhythmia, which favors with the diagnosis. So one is the constrictive pericarditis. I think this recall has been very consistent and disease is the same. In the second one also repeated means repeated dynamic auscultation. I have been always telling you they always ask the exception to the rule MVP or HOCM. So in the patient with hypertrophic cardiomyopathy, which will increase the murmur in this condition. So I always tell you all the conditions which are going to reduce the preload or afterload, reduce the murmur. But in HOCM, they are going to increase the murmur. So increase in the murmur is going to be with the Valsalva maneuver. Will be with the Valsalva maneuver. This is clear. Everything very commonly question we are asking. So yes, so match the following was also very clear. When the patient has got the PSVT, when there is a regular rhythm, we had got the PSVT. Where there is irregular rhythm, flutter was this, the flutter was there. There was atrial fibrillation was present. There is the PSVT present and ventricular tachycardia was there. This is just the matching the options you can choose in the exam correctly. I'm sure we got that option right. Most of you identified the ECG where patient is having irregular RR interval with narrow QRS complex tachycardia, atrial flutter, typical sawtooth appearance on the X-ray, on the ECG, PSVT, where again we have got narrow QRS complex, tachycardia with regular RR interval. There is the VTAC, broad QRS complex with regular RR interval. That was the matching options. We leave it to the examination. Yes, it was basically here we are going to get that. Yes. Okay. Then we have got which of the following drug will cause the torsades point if given with erythromycin. So we said that along with erythromycin, whenever we are going to give antifungal or antihistaminic, it was banned because of this. The antihistaminic drug estimazole was banned because it was associated with risk of torsades points. Associated QT prolongation, we have written down the group of drugs here. When patient presents with shortness of breath and there is echocardiography shows diastolic collapse of the ventricle, early right ventricular diastolic collapse, answer is always cardiac tamponade. And in the cardiac tamponade, the treatment is emergency pericardiocentesis. The treatment is emergency pericardiocentesis. We have got the answer. What is the next best step in management of pulseless patient with following rhythm? When there is pulseless, there is no question but to shock. Now, honestly, the ECG is not very clear. So probably it was a patient, probably it was a ECG of VFib. So pulseless patient in VFib, you will give the defibrillation and continue chest compression. Defibrillation and continue the chest compression when the patient is having pulseless ventricular fibrillation. Hypertension patient with irregular pulse. So patient is having probably atrial fibrillation. Atrial fibrillation is present, and because of loud P2 indicates pulmonary hypertension. So probably patient is case of mitral stenosis. In mitral stenosis, irregularly arrhythmia is atrial fibrillation. So we are going to get absent A wave. Absent A wave on the JVP. We are going to get here. Patient with CKD, ECG is recorded below. It is likely to be hyperkalemia, where there was students reported it was tall T waves are present on the ECG. So there is a ECG of hyperkalemia. When a 60-year-old lady presents with shortness of breath, angina, having aortic stenosis, we said mechanism of angina, most prominent symptom in aortic stenosis is due to increased oxygen demand because there is massive pressure overload state. There is the pressure overload state on the left ventricle. That's why patient has got risk of developing angina in patient with aortic stenosis. A patient presents with joint pain having pansystolic murmur, that is mitral regurgitation, with negative rheumatic factor, elevated ESR. Clearly, it was a case of acute rheumatic fever. A case of acute rheumatic fever was present. A patient presented with the wheezing. Patient presented with wheezing that improves with as needed use of salbutamol, albuterol. The FEV1 was low, obstructive pattern is there, but patient is still experiencing nighttime chestness twice a week, not controlled. If it is not controlled, you want to start with inhaled corticosteroid. We want to start the patient on inhaled corticosteroid. You want to give for the prophylaxis. When a patient presents with the following ABG value, what was correct? So we saw here that the pH was 7.20, that was going down. So there is acidosis in the patient. The bicarbonate was 6, so also going down. There is primary metabolic acidosis. Along with that, we calculated anion gap, which was 136 minus 110 plus the 6, that is equal to 20 milliequivalent. That is high anion gap metabolic acidosis was present in this ABG. High anion gap metabolic acidosis present in this ABG. A patient came with hypotension. There was hyponatremia, that is suggestive of the adrenal insufficiency. It is suggestive of the adhesions, and the patient is having blackening of palmar creases, that is indicating raised ACTH state. There is the raised ACTH state is present, right? Raised ACTH is present. So Karthik is asking why not A. So see Karthik, the thing is it is lack of control. What do we say? Only SABA, but there is no control. Target of control is that we want to have less than 2 attacks per week. We want to have less than equal to 1 nocturnal attack per week. This patient is having 2 nocturnal attack, no? Patient is having 2 nocturnal attack. So target is not achieved. Only albuterol already given. Target is not achieved. That's why we want to add the inhaled corticosteroid. It is not yet controlled. Spirometry is controlled, but spirometry alone is not enough. The target of prophylaxis is not achieved. That is why you want to add inhaled corticosteroid in this patient. In this patient, because there is additions, it could have been primary, secondary, but ACTH is high. That's why primary adrenal insufficiency. Primary adrenal insufficiency is going to be seen. In secondary, if it was outside, then it would have been low ACTH state. That is why correct answer is C. A physician was evaluating patient with occupational disease. This was spot answer. Coproporphyrin test is done. Answer is lead poisoning. Coproporphyrin test is done means answer is lead poisoning. If an alcoholic patient came with 10-day history of binge drinking, altered sensorium, slurred speech, unconsciousness, so patient has come in the Wernicke's encephalopathy, can be there. Wernicke's encephalopathy, blood glucose level is 49. But before you give dextrose, you want to give thiamine. Followed by dextrose. That was also consistent recall. So you can be certain about this. Patient came with perioral pigmentation, hypotension, hyponatremia. Again, this is Addison's. So probably in one paper they asked us Addison's diagnosis. Here they asked us treatment is to give hydrocortisone. The treatment is to give hydrocortisone in this patient. A patient comes with fatigue, fever, 102 and X-ray, digital clubbing. We have discussed in class now. Early cause of digital clubbing is also abscess. So when there is a circumscribed lesion, air fluid level, answer is going to be lung abscess. Foul smelling sputum, all these are keywords we have discussed repeatedly. I keep reminding that clinical questions are back. Please look at the clinical scenario rather than just one test or one single one-liner, right? So 19, patient has got a pleural fluid. Again, very typical clinical question. And lights ratio, lights criteria, greater than 0.5. If it is greater than 0.5, it is exudative effusion. Lights criteria, exudative effusion is there. And most common cause is tuberculosis. Most common cause is tuberculosis followed by RA followed by neoplasm. We could have had all these points here, but typically it is going to be tuberculosis. This also, I think, consistent recall is there. We are confident. Patient came with acute epigastric pain, serum lipase level. Patient is having pancreatitis. Almost literally same case Dr. Bharat has discussed. Same case Dr. Bharat has discussed. Pancreatitis, similar X-ray. There is going to be ARDS is present. Non-cardiogenic pulmonary edema. ARDS is called as the non-cardiogenic pulmonary edema due to profound systemic inflammation like condition with pancreatitis. In this patient, when a 62-year-old patient came with left arm and leg weakness with right-sided facial palsy, so there is a crossed hemiplegia. Crossed hemiplegia already told me that there is a brainstem infarct, but where in the brainstem we wanted to know. This also INICET direct question I have given you. In every single revision, whenever CNS is there, no, even before revision that we did, in the CNS revision, mini test series that we did, brainstem syndrome पूछना ही है, aphasia, brainstem syndrome, repeated question, Parkinson plus. So this was associated with lateral rectus palsy. Once you have got lateral rectus palsy, nystagmus, 6-7 nerve palsy, it has to be midbrain. Sorry, it has to be Pontine syndrome. 6th and 7th is always Pontine syndrome. Foville syndrome. It was 3rd nerve palsy, midbrain. 6-7 pons and lower cranial nerve, medulla. Lower cranial nerve was medulla. Foville syndrome. Gaze palsy is there. Patient came with history of Wilson's disease with neurological manifestation. What would be best to test? When they ask you the question, best, gold standard. Gold standard is always biopsy. Gold standard is to go for biopsy. Look at the hepatic copper content. Best diagnostic modality is always to do biopsy. They have not asked you screening, confirmatory test. In this patient who is having hypertension, atrial fibrillation, shortness of breath with bilateral basal crackle. This was follow-up question. When the patient, what was the question, Krishna? How to differentiate MGS means what? MGS, if you can just elaborate. So here atrial fibrillation, patient has come with heart failure. Patient is having AFib with heart failure. So you want to give anticoagulation, you want to give cardioversion, you want to give digoxin because it is positive inotrope action. But in heart failure, what you don't want to give is beta blocker. Beta blockers is not to be given. Okay, Millard-Gubler syndrome. How to differentiate from Millard-Gubler syndrome? Here there is no rectus palsy. No, there is no gaze palsy. There is only 6-7 but no gaze palsy in the Millard-Gubler syndrome. Okay, got it. So we have got here stopped beta blocker, not to do because heart failure is there. Beta blocker is negative inotropic action. Later we can control rate. Right now for control of rate with heart failure we have written in the class 5 agent beta blocker, no. Rather than that you want to give the digoxin. You want to give. Chalo. PR interval was measured at 0.21 second. 0.21 second means prolonged PR, also called first degree block. Prolonged PR, also called first degree block. Direct questions. The questions were very basic, very clinical questions. ABG shows here also patient had metabolic acidosis. In the metabolic acidosis, anion gap was 136 minus 102 plus 6, that is 18 milliequivalent. So here also metabolic acidosis with high anion gap. So paper 1, paper 2, metabolic acidosis, high anion gap, metabolic acidosis was present in both. I am sure this was there. Myasthenia gravis on mycophenolate mofetil develops hypercalcemia. Hypercalcemia, forget myasthenia. Of course, myasthenia we are all familiar with thymoma, but hypercalcemia we have studied most common with squamous cell carcinoma, seen in the squamous cell carcinoma of lung, that is part of non-small cell. Squamous cell is the non-small cell carcinoma. That is correct answer. Very good, correct answer, got it right. Most common cause of death in IPF, in ILD, answer is the respiratory failure. In ILD we have written chronic cough with intermittent exacerbation. It is the exacerbation more than the pulmonary hypertension which causes death in patient with ILD. Causes the death in patient with ILD. That is taught by clearly Dr. Bharat has taken this answer here. Patient with large sweaty hands, macroglacia and frontal bossing. We are thinking of acromegaly. Any increased GH state, the diagnostic test is suppression test. Diagnostic test is always the suppression test. Right? So this is what we got quite concretely from the recall. I know that many students also reported that there is a case given related to the pulmonary renal presentation. There was pulmonary renal syndrome with pauci-immune deposit. Pauci-immune deposit was there, which was likely to be MPA, microscopic polyangiitis, vasculitis syndrome. The vasculitis syndrome, polyangiitis, all these are the recurrent topics we saw. So unfortunately, I am not the expert on giving you speculation about when the result will come. So I am always requesting, focus on what we know. What we don't know, let's not try to meddle with it. Let us try to spend the time wisely, probably recreate, rejuvenate yourself. You have been through a grueling exam. Wait for the result and then we will take it forward, right? So this is all we have from the medicine department, from Dr. Arvind sir, Dr. Achin, myself and Dr. Bharat and Dr. Rahul Nikumbe. All the very best to you. Already you have done well, only report is awaited. May you get your dream branch.